Ladies and gentlemen, distinguished guests, and esteemed colleagues, welcome to the VA Research Week's Veteran Engagement Discussion Panel. My name is Juan Carlos Ramirez, and I am honored to serve as your moderator for today's event. As a U.S. Army veteran and current MD PhD student at the Baylor College of Medicine, I am deeply committed to understanding and promoting the incredible advancements being made in the fields of medicine and research, especially as they pertain to our veterans and active military. This year's theme, Cutting Edge Care Through Research, underscores the transformative power of VA research in shaping the future of healthcare for our nation's heroes. The VA Office of Research and Development encourages veterans service organizations, VA employees, and all stakeholders to join us in exploring the tremendous impact that VA research has on health and well-being of veterans. Today's event will highlight the perspectives of veterans and Army reservists while providing insights into their interactions with research at the VA. Our panelists will also showcase groundbreaking research, scientific research, and perspectives from Michael E. DeBakey, Veterans Affairs Medical Center, and research personnel, giving us a comprehensive understanding of the current state of innovation in veterans healthcare. VA research has long been the driving force behind the introduction, federal approval, and mainstream integration of new technologies in the clinical environment. These innovations have kept the VA at the forefront of numerous medical milestones and have ensured that cutting-edge research is now more robust today than ever at the VA medical centers nationwide. Together, we will delve into the inspiring world of VA research and its unwavering dedication to improving veterans' lives through healthcare discovery and innovation. I invite you to actively participate in this important discussion and conversation as we explore the remarkable advancements being made in the name of cutting-edge care through research. Next slide. Slide before that. So our task for today's discussion is to explore the unique perspectives of veterans, clinicians, and researchers on research conducted at the Michael E. DeBakey Medical Center. Our purpose is twofold today. One is to enhance veteran engagement in research activities, and two is to gather valuable feedback from veterans. By doing so, we aim to improve veterans' lives through healthcare discovery and innovation, ensuring that their voices are heard and their experiences are taken into consideration in the ongoing pursuit of cutting-edge care. Next slide, please. During today's events, we have a dynamic lineup of activities to engage and inform our audience. We will begin with a few words from our distinguished guest speakers, followed by a presentation on the multifaceted approach to caring for our veterans. Next, we will explore the relationship between veterans and research from both sides of the fence, and then delve into the world of clinical trials for difficult-to-treat major depressive disorder. Finally, our event will culminate in a stimulating panel discussion where we will bring together various perspectives and insights to foster a deeper understanding of the critical issues at hand. And now it is with great honor and enthusiasm that I introduce to you our first distinguished guest speaker today. Dr. Drew Helmer is a highly accomplished professional in the field of medical research and healthcare of innovation, and he joins us to share his valuable insights and expertise. Currently serving as the Deputy Director of the Center for Innovation in Quality, Effectiveness, and Safety at the Michael E. DeBakey VA Medical Center in Houston, Dr. Helmer has played an instrumental role in developing and implementing groundbreaking solutions to improve healthcare delivery and patient outcomes. In addition to his influential work at the VA Medical Center, Dr. Helmer is also a professor of medicine in the section of health services research at the Baylor College of Medicine. Armed with a wealth of experience and knowledge, he has dedicated his career to the betterment of healthcare and the development of future generations of medical professionals. Today, we are truly fortunate to have Dr. Helmer with us to share his insights, experiences, and vision for the future of healthcare innovation. Please join me in extending a warm welcome to Dr. Drew Helmer.
Wow, that was quite a build. I hope I can deliver on this. I actually thought I was just coming here to extend my thanks and appreciation on behalf of the research service line, Dr. Laura Peterson, our ACOS of Research and Development. But since you gave me such a nice introduction, I feel like I better do a little bit more than that. I do want to say welcome to, especially to our veterans who are here. This is really for you, and it's really important that you're here. The Veteran Engagement Group, this is part of our Research Week celebration, and we want to celebrate research, but we cannot do research without veterans. We are the VA, we do veteran-specific research, we focus on the needs and the health concerns of veterans, and therefore you are the most critical partner, the most critical piece of what we do with regard to research at the VA. I think Juan Carlos kind of touched on this already, but we do very cutting-edge research. We lead our fields when we do research here at the VA. We improve our knowledge base. We expand our knowledge and we expand our understanding of what's happening. We also improve care, and that is such a critical piece. We are a learning healthcare organization. We want to do better, and we need to understand how things work, sometimes how things don't work so well, and how can we make them better. And then, of course, these things lead to improving lives, improving quality of life, improving function, making people healthier and happier. I also want to celebrate, the range of research that we do here at Michael Lee DeBakey. You're going to hear from 3 of our experts talking about diverse knowledge bases, training, background. You're going to hear about some really interesting scientific content, and we really span the spectrum from the test tubes and the molecules, that bench research that is so important for getting at the fundamentals of how things work, to the bedside where we're actually translating some of that knowledge into where it matters in terms of making a difference in a patient's life. And then I called it the beyond, but that's actually where the health services research, the epidemiology, and the population health comes into play, where we can actually translate some of that information about how things work back into the science and back into making things better. So I guess I was intending to be brief, and I'll keep it brief, so I'll just say thank you again for being here. Thank you again to the veterans for your partnership, your trust, and your contribution, your essential contribution to VA research so that we can make your lives better. Thank you.
So it is my immense pleasure and respect that I introduce to you our next speaker for today's event, Dr. Mark Kobelia. He is a distinguished and accomplished leader in the medical field, and we are truly honored to have him join us today to share a few special remarks. Currently serving as the Chief of Staff at the Michael E. DeBakey VA Medical Center, Dr. Kobelia has dedicated his career to advancing healthcare services and ensuring the best possible care for our nation's heroes. Under his guidance and visionary leadership, the Medical Center continues to excel in providing top quality care and pioneering innovative healthcare solutions. Today, we have the unique opportunity to hear from Dr. Kobelia as he shares his wisdom, experiences, and thoughts on the challenges and triumphs that come with leading one of the nation's premier healthcare institutions. His dedication to improving healthcare for veterans is both inspiring and commendable. Please join me in extending a heartfelt welcome to Dr. Mark Kobelia.
All right. First of all, he's doing a pretty good job, isn't he? This is probably one of the most nerve-wracking jobs to try and host something like this, and I'm pretty impressed. So he signed, he's a brilliant guy. He signed up MD, PhD training and original research, and I suspect he'll identify this as probably one of the most difficult tasks that we put on him. All right, so I'm a veteran, 34 years in the military. I am a patient of this facility. I have had the honor of taking care of soldiers, airmen, Marines, sailors, Coast Guardsmen in our nation's finest military facility, Walter Reed National Naval Medical Center, and on the battlefield, and everywhere in between. And I will tell you that William Mayo, one of the original Mayo brothers, famously said that the only victor in war is medicine. And what he's really referring to Because, I mean, they enculturated this idea of research and education is absolutely integral to clinical excellence. It's been proven in the best healthcare systems. The VA continues that legacy, but the only way we can be sure to deliver the best possible complex healthcare in a difficult environment against very tenacious disease patterns is to conduct research. It's the only way we can be successful. It's been proven over and over again, and we're proving it right here at the Houston VA. We're named after a very famous researcher who was a veteran himself. Many of us have served. All of us are serving now in service of the veterans. The research that we do may or may not touch a veteran here at the Houston VA, but it almost assuredly will contribute to the veterans' health care, and much more importantly, to all American health care as we move forward. So I always like to remind us that research and education are absolutely integral to our commitment to clinical excellence, that they have to go together. And so that's always sort of a way to introduce it. It's not that we're experimenting in the sense of, it's a population available to us. That's not what we're doing here. What we're doing here is our veterans, today's veterans, are faced with complex illness and illness that we still haven't quite figured out how to do better on. And the only way we're going to figure out how to do better is in highly controlled, disciplined, formal research. And I'm so glad that we embark on Research Week to sort of pause and catch our breath, see what we're working on, what is working, celebrate the wins, and then redirect where we need to. So that's sort of my perspective. Now, Juan Carlos said, the challenge of leading. Let me be clear. The only challenge in leadership at a hospital like this is for me to get out of the way. So with that in mind, let me get out of the way so we can turn the microphone over to people who actually know what they're doing. This amazing group here, 2 veterans, for sure. No? But you're taking care of veterans, so I love you. And you need to hear from these people. It's amazing, and Ray and Aaron are doing incredible work. Not only are they thoughtful investigators, but they're actually brilliant clinicians, and I'm really excited to hear more. So anyways, let's get started. Thank you.
Now it's a distinct honor to introduce our distinguished guest speaker, Dr. James T. McDevitt. As a highly accomplished physiatrist with over 20 years of experience, Dr. McDevitt is affiliated with multiple renowned hospitals in the Houston area, to include the Baylor St. Luke's Medical Center and the Texas Children's Hospital. Dr. McDevitt's expertise in rehabilitation and neurorehabilitation has significantly improved the quality of life for countless veterans and patients with disabilities. Dr. McDevitt currently holds the positions of Executive Vice Chair and Dean of Clinical Affairs at the Baylor College of Medicine, where he is also a tenured professor of physical medicine and rehabilitation. Furthermore, he serves as the Chief Clinical Integration Officer of the St. Luke's Health System and as the Chair of the Board of Directors of the American Board of Physical Medicine and Rehabilitation. Dr. McDevitt continues to make groundbreaking contributions to the field through his impressive academic research and clinical accomplishments. Although Dr. McDevitt could not join us today in person, he has prepared a video with special remarks. Please join me in extending a warm welcome to Dr. James T. McDevitt as he shares his insights and expertise with us today.
I'm Dr. James McDevitt, Executive Vice President and Dean of Clinical Affairs at the Baylor College of Medicine, and I am truly sorry that I could not be here for today's conference, which I think highlights some of the reasons why this VA, in my opinion, is the best VA in the country. I want to review why I believe that, and there are really 3 things I would like to highlight. First of all, the relationship between the VA and the Baylor College of Medicine, one of the premier medical schools in the country. That relationship, as many of you know, was the first medical school VA relationship in the country. It's been in place for more than half a century and is the model upon which all other academic relationships in VAs is built. Importantly, that relationship with Baylor helps to foster a real spirit of science and inquiry that creates a virtuous cycle. It allows us to hire really great researchers, clinicians, educators to work in our VA system. And they all work collaboratively to improve the care of patients we deliver. Secondly, today's about leadership. Everyone that you see speaking to you today is a leader in their field, and they come to work every day working tirelessly to improve the care of patients. And lastly, I'd like to highlight the inclusion of the Veterans Engagement Panel. This reflects a sincere commitment to actually listening to the voices of the people we serve. It's only by actually listening to the people that we can deliver care that addresses issues that are important to the patients, not just important to the providers. So that's what today represents for me. I think that this is an exceptional model for the care of veterans, but more importantly, I think this is a model of care for the entire nation. So thank you for being here today. I hope you have a fruitful and productive day, and I hope I can be with you next year.
Thank you, Dr. David. And now it is with great pride and admiration that I introduce to you our first panelist for today's discussion. Dr. Erin Greenleaf is a highly respected medical professional with an unwavering dedication to the care and well-being of our veterans. She currently serves as the United States Army Reservist with the 628th Forward Resuscitated Surgical Team, showcasing her commitment to our nation's servicemen and women. Her medical expertise and research focus on vascular surgery have contributed significantly to the advancements in medical care for our armed forces and beyond. In addition to her work in the Army Reserves, Dr. Greenleaf has been instrumental in bringing new perspectives and innovative solutions to the field of vascular surgery. Her dedication and passion for her work are truly inspiring and have made a lasting impact on the lives of countless veterans. Today, we are extremely privileged to have Dr. Greenleaf with us today to share her expert knowledge and to discuss the importance of a multifaceted approach to caring for our veterans. Please join me in welcoming Dr. Erin Greenleaf.
All right, well, good afternoon. I'd like to thank the VA Research Week committee for inviting me to be here. Like I said, my name is Erin Greenleaf. I'm one of the vascular surgeons here at Michael E. DeBakey VA. I'm also a U.S. Army Reservist, and we'll touch on both those things in a few minutes. Just next slide. Yep, perfect. Okay. So I'll start by telling you a little bit about myself and how I got to be where I am today, why I'm here in front of you. So I grew up in the Northeast. Which probably means that, to you guys, being raised right outside of Philadelphia, I know cheesesteaks and disappointment in sports teams, which sort of become very acquainted with. I attended medical school at Jefferson Medical College, went west for about 2 hours west. Did my residency 7 years of general surgery at Penn State College of Medicine. Where it was a really formative time for me. I met some good people, including a couple mentors who were colonels in the U.S. Army. And knowing that I was going to vascular surgery and pursuing a vascular surgery fellowship, it really occurred to me that between general surgery and vascular surgery, I would kind of hit the sweet spot for caring for our veterans, caring for combat-related injuries. And it was out of a sense of duty and knowing the mentors that I had and their guidance that I commissioned with the U.S. Army Reserve. So in 2019, I commissioned as a major as a 61 Juliet, which is a general surgeon, started my vascular surgery fellowship, and then 2 years following that, I found myself here in Houston. I'm grateful for this position here. I think I'm one of 3 vascular surgeons here at the Michael E. DeBakey VA. We do upwards of 1,200 operative cases per year, which is a busy clinical service. I believe it's the busiest vascular service among VAs in the country. We have a robust educational mission. We train fellows and the integrated vascular surgery residents. And then we are incredibly productive academically. And I'll tell you a little bit about just 3 studies that we have of the many going on here in the vascular surgery division. Next slide. So to begin, we have the TOP trial. The TOP trial has been going on for a few years. It's a national clinical trial, and it's specifically aimed at addressing the knowledge gap of postoperative transfusion thresholds in a patient population that has high cardiac risk, who are undergoing major surgical interventions, because those patients are currently treated with data that's limited to a patient population that doesn't have the same high cardiac risk profile. As we know, blood is a limited and costly resource. It would be great to say that we had a limitless amount, but we don't, and this is one of the many reasons that we hold off and we're judicious in transfusing patients when we do. That being said, there are patients who have cardiovascular disease who are at the highest risk of adverse events when they become anemic. Next slide. To expand on that briefly, the body is reliant on oxygen delivery to all your tissues, and that delivery happens via red blood cells. And so you can imagine that when a patient has heart disease and is depending on as much oxygen as they can get to the heart, they're at particularly high risk of a heart attack, among other major complications. So thus far, physicians have had to extrapolate guidelines from other studies, other patient populations to determine when to give blood. But that's just not safe. Next slide. And so we sought to compare patients getting treated with a liberal transfusion threshold with a hemoglobin of 10 milligrams per deciliter to those having a lower transfusion threshold at 7 milligrams per deciliter, and comparing their postoperative outcomes, looking at things like heart attack, stroke, and other complications. The study is a huge national trial. We actually concluded recruitment just a few months ago at 94% of what we expected. And we're proud to say that this site right here was the top recruitment site of the 14 VAs around the country. And so, we'll be analyzing data and hopefully have publishable results in the next year. So I'm excited for that. Next slide. Now, the next study I want to talk about is one regarding EGAR surveillance, and that's important because there are, next slide, about over 8,000 veterans per year who are treated for abdominal aortic aneurysm. And over 70% of those are treated with what's called endovascular abdominal aortic repair, which is a stent covered in fabric used to reinforce the weakened aorta. And just to back up a little bit, the aorta is the major arterial blood vessel going through the body to deliver blood from the heart to the extremities. Now, when patients get this repair, the FDA dictates that there's mandatory surveillance with a CT scan, a contrast-enhanced CT scan every year. And you can imagine for patients who are in their 60s and 70s, that's upwards of 15 to 20 contrast-enhanced CT scans, which is a huge contrast and radiation burden for them. So we've been doing this. This is a relatively, in the grand scheme of grand history of vascular surgery, this is a relatively recent procedure, about 20 years old. And so now we're going back and we're going to really reassess what our veterans think, what their families think, and what our healthcare team members think about that surveillance protocol and that heavy burden of radiation and contrast that they get. We're going to actually look at the risks, benefits, and outcomes after those procedures to determine, is that yearly surveillance protocol necessary? Next slide. And last but not least, one of the more recent studies that we've initiated here is looking at in-theater vascular repairs during the global war on terror. So vascular-related wartime injuries affects approximately 20% of adult combatants. And really how we manage this over time has changed. More recently, it's been accepted that bypasses in theater in the field are the way to manage these if possible. And so what we're going to do is we're going to pull data from the Department of Defense, and we're going to assess the clinical effectiveness of the various approaches to the vascular trauma used in these contemporary war-related injuries. But perhaps more importantly, what we're going to do is we're going to partner with the medical community around VAs around the country to really make sure that those patients who are getting those repairs in theater are being surveilled when they come over to the VA system. Next slide. What we found was that transition from the military health system to the VA is not a seamless one, and a lot of patients get lost to follow-up. So what we're trying to do nationwide is to ensure that their patients and their medical records are experiencing a seamless transition from the military health service to the VA, to create a system whereby patients with combat-related repairs are matched with the appropriate follow-up within the VA, and to provide checkpoints for patients and providers to ensure that their bypasses are remaining patent as long as possible. Next slide. So just to conclude with a few final thoughts, there's a multitude of research studies being done right here at the Houston VA within our division, including those aimed at managing symptomatic anemia, effects of lifelong imaging surveillance, and the transition from the military health system to the VA. But the Houston VA Vascular Surgery Division is just a fraction of what's being done at the Houston VA, and certainly a much smaller fraction of what's being done at VAs nationwide. So when I think back to why I commissioned with the U.S. Army Reserve, I was looking to treat and take care of patients who are the most deserving of excellent care. And I think the combination of the clinical impact we're having combined with the research done here at the VA is really getting at that aim. Thank you.
Thank you, Dr. Reed. And now it is with great honor that I introduce to you our second guest panelist for today's discussion. Dr. Donald Lazarus is a United States Army veteran who brings a unique and invaluable perspective to our panel, focusing on both sides of the fence of veterans in research and research for veterans. Currently, Dr. Lazarus holds the position of staff physician at the Michael E. DeVakey VA Medical Center, where he contributes significantly to the advancement of healthcare for our nation's veterans. Additionally, as an assistant professor of medicine at the Baylor College of Medicine, Dr. Lazarus plays a pivotal role in educating the next generation of medical professionals. With firsthand experience serving in the United States Army, Dr. Lazarus has a deep understanding of the challenges faced by veterans and is passionate about enhancing their healthcare experiences through groundbreaking research and innovative solutions and practices. Today, we are privileged to have Dr. Lazarus with us to share his invaluable perspectives on the intersection of veterans care and medical research. His dedication to this crucial area of healthcare is truly inspiring and has made a significant impact on the lives of countless veterans. Please join me in extending a warm welcome to Dr. Donald Lazarus.
Thank you. Go ahead and go to the next slide. Okay, so what I'm going to try to talk about for you today are really three things. The first is to talk about what I see as the benefits of medical research for veterans as well as civilians in the U.S. I'm then going to talk a little bit about my perspective on research as a researcher, because I participate as a researcher in several trials here and have in DoD as well. And then I'm going to end by talking a little bit about my experience as a research participant, because I think if we really think that it's important, we should put our money where our mouth is, and those of us who are here as veterans, when there's the right kind of trial, should be willing to participate in that too. So this is my bona fides. So I went to undergrad at Texas A&M and then medical school there also, but I paid for that with an Army Health Professions Scholarship. And so after that, I was really fortunate enough to go to internal medicine residency at Walter Reed in DC, which was, at that time, in my opinion, biased, admittedly, the best internal medicine residency in the country. After that, I served at Fort Hood at Darnell Army Medical Center, including a deployment to Iraq with 1st Battalion, 67th Armor from 4th Infantry Division. That was OIF 0507. So we were in the Triangle of Death, which you can see in the little map off to the side. After that, I left active duty and came to Houston, where I trained in pulmonary critical care at Baylor College of Medicine, including about a third of my time here, and then interventional pulmonary training at MD Anderson.
And in 2015, I was fortunate enough to be able to come back here, and I've been here ever since. So what does research do? There are a few different kinds of research that I think you should be aware of. First, there's basic work, and that's physiology, pathophysiology, pharmacology, learning how the body works and what goes wrong in certain disease states. And if you understand that, then you can start to understand how maybe to prevent some of the conditions that we face or to treat them. Secondly, you can use different types of research to develop new ways to address issues and problems that veterans and other people face. This could include things like new diagnostic tests. It could include new treatments and things such as that. Finally, the other form of research that I'm interested in and participate in probably the most is figuring out which sort of existing treatments, things we already know, work the best for certain conditions, because a lot of them have been developed and we know that they're effective, but we don't know what's best in certain situations. And so that's where comparative research I think is also important. So why is research important for veterans in particular? So I think that veterans have unique and unusual risk factors for diseases that are uncommon in the general population. I think we all know about Vietnam veterans in Agent Orange and how long it took for some of those conditions to be recognized. And because they weren't common in the civilian population, I think there was a delay in realizing the effect that that was having on our returning service members. Some treatments that are tested only in civilians may not work well for the unique situations that veterans have. There are also some medical questions that can only be answered in an integrated system as large as the VA. It's the largest integrated healthcare system in the United States, one of the largest in the world. And for certain rare conditions, you need a lot of patients to get enough numbers to actually fully understand what's going on. And the VA is in a unique position to help us understand those things. Finally, veterans are altruistic, and a lot of us want to continue serving in some way even after we leave active duty, and this is one way that we can do that. This slide is just here to show you some of the important medical advances from VA and DoD. I'm going to kind of dovetail on something that Dr. Greenleaf said already about seamless transition of care from active duty to veteran. I think it's the same for research. It's a continuum. They're not separate. The same sort of things that DoD is interested in, VA is interested in. And sometimes it's just that they're in a different place in the timeline for the individual patient or group of patients. So DoD, blood transfusion, trauma surgery, damage control, resuscitation, treatment and prevention of various infectious diseases, artificial limbs. VA also, the original link of smoking and lung cancer came from a VA pathologist at the New Jersey VA. First pacemakers were done at the VA. Link between hypertension and health problems and death was initially established by VA researchers. VA physicians pioneered kidney transplant and also transcatheter heart valve replacement. This VA was one of the pioneers of that treatment. And then one more shout out to Walter Reed. Walter Reed was an Army officer who led the Yellow Fever Commission in Cuba during the Spanish-American War, and figured out that mosquitoes actually were the vector spreading yellow fever. And this has not only helped us control yellow fever, which used to give you yearly epidemics in New Orleans and Philadelphia and other places in the U.S., but also other infectious diseases like malaria. Dr. Oscar Auerbach was a pathologist who worked at the VA in New Jersey, and he was responsible for clearly delineating the link between smoking and lung cancer. And just figuring that out has led to saving millions of lives through smoking cessation programs and other things. So just two concrete examples. So I'm going to switch gears a little bit and talk about the things I'm interested in clinically in research. And so lung cancer and other cancers of the chest are at the top of the list. Other kinds of airway disorders, pleural diseases, which are diseases of tissue around the lungs but still inside the chest. Procedures used to diagnose and treat those conditions, and then critical care medicine. And there are 3 trials that I am or have been involved in as a researcher that I'm going to highlight just to show you kind of how VA and DoD research is helpful for all of us. So this is the first one. This is a VA Cooperative Studies Program 2005. It's called VALOR, and this is something that we are actively doing now, along with Lorraine Cornwell, who's our cardiothoracic surgeon here. So we know that lung cancer is the #1 cancer killer in the world and in the United States. It's particularly common in veterans who have high rates of exposures to cancer-causing chemicals, as well as high rates of smoking. Surgery is the recommended treatment for early stages of lung cancer, and radiation is an alternative for patients who are too sick for surgery.
There are newer forms of radiation therapy that are more effective and less toxic than the older versions, and no one really knows whether these newer versions of radiation are as good as surgery for early stage lung cancer. They tried to do these studies in the private sector twice, and they failed because they couldn't get enough patients to enroll. And we're currently doing this study. It's been going on for about 5 years now, 20 VA hospitals around the country. The target is to enroll 670 patients, and we're getting close to halfway there. And Houston is the #2 enroller in the nation for the Valor trial. So we should have results probably in about another 6 to 8 years. It's a long-term kind of thing. But I think it's going to really change the treatment of early stage lung cancer by knowing this information. If we know surgery is better, great, no doubt you push for surgery. If we know that the surgery is not better, then it's a very different conversation you have with the patient when they're diagnosed with this condition. This is a trial that I was involved in when I was still on active duty, and I bring this up because I want to point out to you how sometimes in real time, short periods of time, research can change the kind of care that you provide to patients. So in the early years of the Iraq War, we found that a lot of the troops who were coming back wounded from theater were colonized with Acinetobacter, which is a very difficult to treat bacteria that's resistant to a lot of our antibiotics. And it caused a lot of wound infections and those prolonged recovery. And the original hypothesis or theory was that they were picking this up in the soil in the region because it is known to exist in the Middle East. But they weren't really sure. And in order to figure out a way to decrease the rate at which soldiers were coming back with this, they really had to figure out where they were picking it up. So we did a study that was actually fairly simple. And we collected skin swabs from soldiers downrange and tested those to see if any of them were carrying Acinetobacter. And as it turned out, almost none of them were. The next step after this study was published was they tried to figure out what the first step in that chain when a wounded soldier then was evacuated to Combat Support Hospital, then to Landstuhl in Germany, then to Walter Reed and Brooke in San Antonio, where it was actually being picked up. And it turns out it was the hospital in Baghdad. So we took over Saddam's hospital, the Musina Hospital in the Green Zone, and that was used as the Combat Support Hospital during the time that I was there. And it was colonized with Acinetobacter, which is difficult to get rid of, and that's where the troops were picking it up. Once that was fully understood, they were able to do some very effective and aggressive sterilization and infection control policies that then decreased the rate of Acinetobacter colonization. So even simple, small projects can actually make a big difference in outcomes for patients. And this last one is one that's still ongoing as well. I work with Dr. Farah Karadman, another one of our pulmonologists, about this. And this is looking at immunology and how your immune system interacts with lung cancer and COPD. So the immune system is a part of the way your bodies fight infection as well as cancers. And if your immune system is not well regulated, it can actually cause unintended damage, such as COPD, or fail to recognize and attack cancers that develop in the body. What we're trying to figure out is, are there things that are different about the immune systems of patients who smoke but don't develop lung cancer, or do develop lung cancer and keep it isolated, that make certain people more susceptible to more aggressive tumors and worse outcomes. And all this really involves is when we're doing biopsies for some other reason, a little bit of that tissue, once the patient gets what they need for their medical care, goes to the lab and they look at the immune cells and try to figure out if there's a pattern or a change that may contribute to some of these things. So as a researcher, I think research in the VA is important because it helps us develop new knowledge and methods for treating our patients. I think it helps patients who are participants in the study through those research interventions, the new procedure you're getting, or something like that. But it also helps you streamline care in other ways, such as the Acinetobacter study that we did in Iraq. It also has the potential to help patients in the future who may benefit from these results once the results of the study are known, which sometimes takes a number of years. And it also helps us share what we know with others, and so some of the things that we can pioneer here can be of use in the private sector later on. So now I'm going to talk a little bit about participating in research as a subject, so one of the guinea pigs. And there are 3 projects I'm going to highlight, one DoD, 2 VA, that I've participated in as a participant that are still ongoing and maybe things that some of you qualify for as well. So the first one is the Millennium Cohort Study. This is a long-term epidemiology study that's looking at how various military experiences affect the health of service members and veterans. It got started at around 2001. So far, they've enrolled more than 200,000 service members and veterans, and its focus is on a variety of things. So they're looking at readiness, mental health, environmental exposures, and then various ways to prevent disease and other things. So far, it's resulted in 200 scientific articles, and for me as a participant, it's very easy. So when you enroll at first, you do an initial survey, and you don't have to even talk to anybody. You're filling it out on paper. So they ask you a lot of questions about where you served, what you were exposed to, what your health is like now. And then every 2 or 3 years, I get another survey in my email or in the mail, and I fill it out again. They send me a postcard ahead of time, so I know to expect it. And what they're trying to do is to figure out how military service affects the long-term health of service members and veterans. The next project I'm going to talk about is the Million Veteran Program, which I see several people in this room who are involved with. It's similar, and it is a national VA research program that so far has enrolled almost 1 million veterans, 930,000 I think the last time I looked. So this looks at similar things to the Millennium Cohort with a little bit extra. So you do a similar sort of questionnaire about your exposures, where you were, what your health is like now, but they also do a single in-person visit with a blood draw. And what they're trying to do is, in addition to looking at the environmental exposures and how they predict health issues in the future, they're also looking at genes and genetics, because it may be that one person who is exposed to a certain thing has no problem, but another person has a big problem because there's a different genetic predisposition. So they're looking at that in addition to just the environmental exposures. And so I think in the future, this is something that may help us streamline prevention as well as treatment for some of the things that various veterans are at risk for. This one is a little bit newer than the Millennium Cohort, but still over 100 scientific publications so far and a lot more coming. And when you decide to participate in these trials, it's pretty neat because you can go to the website and see the publications that are coming out. So you can see the kind of knowledge that your participation as a research subject is generating and how that may be helping other people. This is the last one I'm going to share with you. So this is another VA Cooperative Studies program, 595. They call it SHADE, and Dr. Crodman is also one of the lead investigators of this. I think there are 4 VAs that are involved in this right now, but they're looking at pulmonary and systemic effects of deployment-related particulate exposure, so dust and other stuff in the air that we breathe when we're downrange. So they use satellite-confirmed information about your deployment location and even down to what the weather and climate were like at the time when you were there to look at how exposure to different particulates in the air affect veteran health. And in particular, they're interested in respiratory health, but they're looking at other things too. I'm a lung doctor, so I think about the lung part more. And so what this was like for me as a participant was a detailed questionnaire, including health stuff, but also my deployment history, and even down to the geographic areas where I was in the months and years that I was there. And then you get a lung function test, which they just do there at the bedside, very easy. And it's kind of neat to look at the kind of resources they have in terms of the geography, so they can actually drill down to the specific area in the specific state of the location where you were deployed to. So they get a much better idea because of the weather and everything at that time, what actual particulates you might have encountered. And this slide is designed to show you just exactly that. So this is where I was, and you can see our aid station with nice red crosses on the front, and right behind it, all those smokestacks are the largest power plant in Iraq. They burn crude oil to generate electricity, and they pour smoke into the air 24/7. So you have multiple battalions of soldiers over time staying, living basically around the perimeter of this power plant, breathing that stuff in as well as the dust and all the other things. They had their burn pits, their black water pits. You can see the trash pile with the guard towers behind it. And so we're not unique, our unit being in a place like that. And so there are a lot of risks like this that our soldiers and sailors and Marines and airmen experience downrange. And I think getting on top of this early by participating in this kind of epidemiologic research is really important. So we catch these things before you have a much larger problem. So as a participant, there's really minimal risk or inconvenience to me. I give them just maybe a couple hours in person on an afternoon, and the rest of it is stuff that I can do online or by mail later. I get a free lung test and lots of attention. I get to help researchers answer these hard questions, because it's hard to sort out what causes what, and you need a lot of patience to do that. And that's useful to me about my own service and health, but also about others, and also maybe better ways of doing things in the future. Not just from a medical standpoint, but from an operational standpoint.
I also get the satisfaction of seeing those results published in the medical literature so that people can learn from them. And it's a way to help others without having to necessarily lead a research project. So I'm part of the leadership of the Valor trial and some of the others, but you don't have to be a leader in every project that you're working on. You can be a Joe too, and just participate by sharing your data or your information with the researchers so they can develop this knowledge. So in summary, VA research has been and continues to be a great benefit to veterans and others. I think conducting VA research lets me help my patients as well as others elsewhere and in the future, and participating in this as a subject also helps me contribute to the well-being of the community in a different way, but still be a part of the team. So, thank you.
So now it is my distinct pleasure to introduce to you our third guest panelist for today's discussion. Dr. Sanjay J. Matthew is a highly esteemed medical professional specializing in the field of psychiatry and mental health care with a focus on innovative research and treatments. Currently, Dr. Matthew serves as a staff physician with the mental health care line at the Michael A. DeBakey VA Medical Center, where he is dedicated to providing exceptional care for our nation's veterans. Additionally, as a professor of psychiatry and vice chair of research at the Baylor College of Medicine, Dr. Matthews is at the forefront of advancements in medical health treatment and education. Today, we are incredibly fortunate to have Dr. Matthew join us to share the latest developments in clinical trials for difficult-to-treat major depressive disorder. His dedication to improving the lives of those suffering from mental health challenges is both inspiring and invaluable. Please join me in welcoming Dr. Matthew.
Thank you very much for the invitation and the introduction. It's a pleasure to be here to talk about some of our work here locally and nationally to address depression. And just often people don't realize that depression can be so disabling. I mean, we sometimes use the word depression colloquially, and you're having a bad day or sad, but major depressive disorder is incredibly disabling, causes a lot of absenteeism at work, and 10% of patients in severe cases may go on to attempt or even complete suicide. So the better treatments we can have, we can hopefully quell the suicide epidemic. And so we have about 30 FDA-approved antidepressants, and we've had these since the 1950s. However, the problems with antidepressants are, besides the fact that about half of patients do not achieve remission from getting antidepressants, they work quite slowly. It can take 4 to 8 weeks or even longer for an antidepressant to kick in and have its optimal benefit. There are side effects. There are weight gain, there's metabolic side effects, and so on. And there's any number of reasons patients, veterans, may not adhere to the treatment because there's stigma still about being on antidepressants. They're maybe reluctant to seek care. There may be feelings that this is not an illness, but perhaps a weakness. So there's all kinds of issues that go into individuals' reluctance to continue on treatments. So we have a lot, but what we really need are treatments that can work quickly, effectively, and quell the propensity for suicidal type behaviors. And we know that during COVID, depression increased dramatically during the 2 years plus over the last 2 years, and particularly those with severe depression, the rates have gone up. And when you look at global mental health disability, across psychiatric conditions, mood disorders, which include unipolar and bipolar disorders where not only do you have the depressive lows, but you have the manic highs, which may lead to hospitalization, often associated with addictions, substance abuse, and so on. But these are massive causes of disability. And as mentioned, suicide rates across the country have gone up over the last decade, and we all are very cognizant of the crisis in veteran suicide in terms of suicide attempts and suicide completions. And so despite having a lot of mental health care, a lot of treatments, a lot of psychotherapies. We have not done much, and you can see the heat map of suicide rates by country, and you can see Texas is a lot darker color, meaning higher suicide rates over the last decade. So unfortunately, we have done very little to bend that curve. So what's actually approved for difficult to treat depression? We have electroconvulsive therapy, and that's ECT, sometimes known as shock treatment. It's the administration of brief electric shocks such that the patient under anesthesia has a brief epileptic event, which then leads relatively rapidly to improvements in mood. So it's generally a 3-week course of treatment, 3 to 4 weeks, and the rates of response are quite high. So it's still considered to be the gold standard for very difficult to treat, not only unipolar depression, but bipolar depression, psychotic depression, across the board. So if we have a patient who's not responding, needs relatively rapid care, ECT is still the gold standard. And so some people are surprised to hear that because their only impression of it may be from One Flew Over the Cuckoo's Nest and Jack Nicholson many years ago. And unfortunately, the reputation of ECT still can be quite negative because of concerns about memory loss, cognitive impairment, you can't drive, certainly on Monday, Wednesday, Friday when those are administered. So that there's a lot of patient burden, but it's still considered the gold standard. TMS is something we offer here at the VA on our 6th floor, and it's a non-invasive application of a magnetic coil to the left side of the head, and with 20 to 30 sessions, which last anywhere from a few minutes to 45 minutes, there are improvements in depression. It's an FDA-approved device, well tolerated. Pretty much the only side effect is headache. And then there's a number of medications that are approved in conjunction with the standard antidepressants, which are the SSRIs. The limitations for these are metabolic syndrome, propensity for diabetes, weight gain, and so on. And then what I'll be talking a little bit about is a new innovation, which is a derivative of ketamine. So ketamine is a FDA-approved anesthetic agent. It was approved in 1970 for administration of anesthesia. This is a derivative of ketamine used intranasally, where the patient self-administers it at a very low dose. So it's not an anesthetic dose, so the patient is awake throughout, and it recently received the indication for TRD, which is treatment-resistant depression. So this is just a schematic showing that one of the reasons we're interested in looking at repurposing existing drugs for psychiatric purposes is to discover a new drug takes at least 10 years and $1 billion. And that's if you're lucky in terms of the 10 years. There's many different phases we go through, phase 1, phase 2, phase 3. It's a very time-consuming, costly way of doing things. And a lot of our work has been looking at repurposing drugs we think may be therapeutic in depression as a more expedient, rapid, and efficient way of perhaps getting new treatments out. And there's been a fundamental shift in how we conceptualize the biology of depression over the last 10 to 15 years. There was a lot of interest in the 70s, 80s about serotonin and specific neurochemicals that are believed to be associated with mood states. We know the story is a lot more complicated, and we've been interested in different systems, including the glutamate system, which may be the main information thoroughfare of the brain. We know that neuroplasticity is important in all of cognitive processes, including the ability to learn and grow. And impairments in the growth and connections between brain cells, so-called synaptic connectivity, may be what's fundamentally wrong in depression. So areas that should be talking to each other in the brain are not talking to each other, and areas are inappropriately connected. So essentially, we're trying to change, reshape, regrow those connections. So there's been a lot of interest in ketamine, repurposing that, and that's a so-called dissociative anesthetic. There's also been a lot of interest in repurposing some of the classic psychedelic drugs, and these have recently been studied in depression, including so-called magic mushrooms, which is called psilocybin, and other drugs that are in various stages of testing by the FDA to actually make them approved in conjunction with psychotherapy and other things. So one of the interesting things about IV ketamine, intravenous low-dose ketamine